Hello, and welcome to another episode of Hematology Horizons. My name is Elissa Baldwin, and I'm the Director of National Patient Education at Blood Cancer United, formerly the Leukemia and Lymphoma Society. Today, we are taking you on site at the 2025 ASH Annual Meeting in Orlando, Florida, presented by the American Society of Hematology. This meeting is attended by over 30,000 hematology professionals from around the world to share the latest research in hematology. I am here to take you around the conference to talk to oncology researchers and Blood Cancer United staff and hear the highlights in research that benefit blood cancer patients and their loved ones. As we will be covering several different types of blood cancer today, the diagnoses will be separated into chapters, which you can find in the description of the video. Are you ready? Let's go check it out.
My name is Andy Kolb, and I'm the President and CEO of Blood Cancer United, and this has just been an incredible ASH meeting. I am excited about so many things, but there are three things that really come to mind. First is that, we've been talking about the success of menin inhibitors. We've been talking about the success of CAR T-cell therapies and all that has done for patients and families. And at this meeting, we're seeing what we're going to do next with menin inhibitors. There was a presentation from John Crispino, who's one of our SCORE grant recipients, who's talking about how we use menin inhibitors now for myelofibrosis. There were presentations about using menin inhibitors in combination with other therapies for AML. It's really just incredible how not only did we help bring menin inhibitors to recognition and development and approval, but now we're starting to see how menin inhibitors can help so many more patients with blood cancer than we originally could have ever expected or dreamed. And the same with CAR T-cell therapy. CAR T-cell therapies continue to grow in their impact and their application. We see new innovations, new ways to manipulate CAR T-cell therapies to help more and more patients. It's just incredible. The second thing I'm really excited about is that I got to spend time with our patient support and advocacy teams, and I'm excited about the way that they show up to partner with pharmaceutical companies, to partner with institutions and policymakers to ensure that all patients have access to the therapy that they need and that they deserve. And the third thing that I am most excited about is that, this has been a challenging year. We are having a moment in the United States. We are having a moment at Blood Cancer United. But this meeting, despite all that, is some of the best science that we've ever seen. And it is so exciting to think about what we're going to see coming forward in the next 3, 5, 10 years. And we know Blood Cancer United is going to be a big part of it. And I'm excited for those celebrations. We celebrated the best of the best researchers last night at our Research Awards and Networking event. I can't wait to see what we're celebrating 5 years from now because it's going to be incredible. So great ASH meeting. Really proud to be here representing Blood Cancer United. I wish everybody could be here, but I hope this gives you a glimpse at the incredible work that's happening.
Hi, I'm Loretta Nostville, currently practicing in Durango, Colorado. In my former life, I was a clinical investigator for a number of years at MD Anderson, where I spent a lot of time trying to figure out how can we harness the immune system to eradicate lymphoma cells. And what I realized is there are a number of patients in the United States that are treated in community practice. And so I kind of put myself out there. If I'm going to distribute most of this information and make sure these patients have access to care, I should probably be where those patients are. And so now I'm trying to figure out how to bring these innovative changes in the treatment landscape to where the patients are. And so what am I excited about providing to my patients? I think the bispecific antibodies are clearly having an impact in the B-cell lymphomas. And what we've seen at this meeting, a number of CD20, CD3 bispecific antibodies, either 3-year follow-up where we're starting to see some stabilizing of those PFS curves that may be hints at clearly good durability, but maybe even curative potential of these bispecific antibodies in this third line or later space, either in follicular or large cell lymphoma. So then the next wave is to move these agents into earlier lines and in combinations. And so we're seeing some early phase studies read out either novel combinations with CELMoDs. We saw mosunetuzumab or glofitamab in combination with golcadomide. We saw combinations with CD20, CD3 bispecifics, and BTK inhibitors as early as frontline follicular lymphoma. And then we saw a large randomized phase 3 readout where epcoritamab in combination with lenalidomide and rituximab for relapsed follicular lymphoma as early as first relapse was far superior to lenalidomide and rituximab. So these are clearly exciting therapies, but now the dilemma is how do we sequence treatment as we have more and more effective options? How do we choose between the available agents, whether it's balancing the efficacy or the toxicity profile? But more importantly, how did we deliver this to the patients who need it most? And these are patients that are older, maybe have more comorbid conditions, or they can't travel to these large academic centers. And so I do think there's still an unmet need of educating those community oncologists about the nuances of these different either single agents or combination strategies, figuring out how to manage the toxicity so most of these patients can remain outpatient and stay at home. And also, how do we integrate all these new therapies as they emerge when we're probably still educating them about the trials that read out 3 years ago. So it's an interesting dilemma to have.
Jacob Svoboda, University of Pennsylvania. So there's always many interesting studies that are relevant for CLL/SLL patients at ASH, but I was thinking about bringing perhaps the most impactful ones. And I just came from what we call plenary session, which is really, the committee selects the most important studies in oncology, hematology oncology, and one of them was the first readout of the CLL17 study. And it's a study that was conducted in Europe, led by the German CLL group, and it looked at a very important topic. And as many of you probably know or experience, the discussions when we are planning to initiate treatment for patients with CLL/SLL, those can be very long discussions about the different options. I mean, I think it's wonderful that in 2025 we have several excellent options, but the specifics may really depend on a lot of details and preferences of the patient. So the three options we currently have are sort of BTK inhibitors that are the covalently binding BTK inhibitors that we continue indefinitely. And then we have the sort of time-defined or limited regimens, usually with venetoclax, like venetoclax obinutuzumab or venetoclax with a BTK inhibitor. And this study was actually the first study that looked at these three different options in randomized manner, and it enrolled about 900 patients in Europe with CLL/SLL who needed treatment. And they were stratified based on some risk factors, like some of the unfavorable risk factors like p53 mutation, IGHV mutational status. And basically there were three groups, about 300 each, patients who were on a sort of an older BTK inhibitor that is no longer used very much in the United States, called ibrutinib or Imbruvica, and then combination of venetoclax with ibrutinib that was for about a year, and combination of obinutuzumab with venetoclax, again, used for about a year. And I'm not going to go into any major details, but basically it was what we refer to as a non-inferiority study, meaning they were not necessarily looking is one better than the other, but it was really looking is one worse than the other, especially since the duration of treatment, it's an important component. And so we the kind of message or the result was that there was no difference in the overall survival or progression-free survival at 3 years. So this was the first readout of this important CLL17 study. How will we interpret it in our practice, in day-to-day practice? I think it's very helpful to have that information kind of perhaps favoring the limited duration of treatment. But the trick is that we don't use ibrutinib in the United States anymore. So is it really relevant to the current practice? There will be, I think, a little bit of a controversy on that. We use acalabrutinib, zanubrutinib usually when we use a BTK inhibitor because of the toxicities. I think there's also a new generation of BTK inhibitors, the non-covalently binding BTK inhibitors like pirtobrutinib. And again, we're sort of excited to see that some of the studies are trying to move this one closer to the front line or to the front line. So really, I think that this is the issue with clinical trials. They are being designed, and then the protocol is written, everything takes time, and by the time we get the results, there may be different options. So, but I think this is perhaps the most impactful study of ASH 2025 for our CLL/SLL patients. In terms of the relapse refractory disease, kind of the opposite end of the spectrum, our group has been involved in CAR T therapies for CLL patients, and there's a growing group of patients who we sometimes refer to as double refractory, patients who already had BTK inhibitors, patients who had venetoclax-based therapies, and now they have active disease. So what do you do because they already had the best-in-class drugs? So we do have one CAR-19 product currently approved in the United States for CLL/SLL for these double refractory patients. But unfortunately, when we look at the pivotal trials and even in our experience, the complete response rates are suboptimal. So the reported complete response rates are about 20% in these double refractory patients. So there's definitely room for improvement, and that was part of our efforts using a new generation of CAR T cells that are not only able to target CD19 on malignant lymphocytes or on lymphocytes in general, but they also have the ability to secrete IL-18, which is an interleukin 18. It's a cytokine that in preclinical studies improves the efficacy of this product. We did publish our earlier cohort using this product with non-Hodgkin lymphoma. This is the first time we presented the data on CLL/SLL patients who already had prior BTK inhibitor and venetoclax. And it's a very small numbers, but we've seen some encouraging results. Basically 43% response rate, CR rate. These responses seem to be very durable. So there's one patient who's now going 2 years in complete response. And the toxicities, they are toxicities that we expect with CAR-19 in general, like CRS and neurotoxicity. But none of these toxicities resulted in death of the patient or any permanent effects that we saw. So basically our conclusion about this armored CAR T or IL-18 secreting CAR T study is that we should go ahead and continue to use this and investigate this type of product in our refractory relapse CLL/SLL patients. So I'm super excited about the fact that we now have more information for our discussions with patients about the best frontline treatment, and that the fixed duration therapies are very effective in the long run, and I think that will be very helpful for providers and patients.
My name is Laura Gruenbaum. I'm the Chief Scientific Officer at Blood Cancer United, and I'm here at ASH. It's Monday already, and this is a really exciting year for patients because we're seeing a lot of innovation. We're seeing really exciting advances with immunotherapy for multiple myeloma, where we now have CAR T therapies moving into earlier lines of therapy. And we're also seeing some novel CAR T therapies, bispecific CAR T therapies that are targeting more than one cancer protein, and also new manufacturing methods that are faster and that lead to fitter T cells, fitter CAR T cells, and that also have a very good tolerability profile. So some of the things we've been concerned about, like cytokine release syndrome and neurotoxicity, we're seeing those much, much less with these therapies. So moving into earlier lines of therapy, and we're even seeing some data for newly diagnosed patients. And we're also seeing CAR T therapy approved therapies where we now have enough follow-up data to see that they're really patients that are having very long-term durable responses, which makes us really think that maybe there's a way that some of these therapies are truly going to cure patients. And then one last little tidbit I want to throw out there for CAR T therapies is that we're starting to see something novel, where the CAR T cells are now being generated in a patient's body, in their bloodstream, and not outside of the body and then being reintroduced. This very early days, but in multiple myeloma, we're seeing the first data indicating that these types of therapies now do give very good responses in patients. They're well tolerated. We are not seeing, again, the usual culprits like cytokine release and neurotoxicity, or very little. We, of course, have to see more patients. They presented data here from a company called Kelonia with 3 patients. We need to see durability, but really exciting. The other part of immunotherapy that's really exciting here are the so-called bispecific antibodies or engagers. And what that does, it's basically an antibody that activates a T cell, again, inside the patient's body. So it's doing something similar to what CAR T therapies are doing, but again, it's something that that a patient, can receive via an injection or an infusion, so something that is much, much easier to manage. We are seeing these also moving from, being something that patients receive when they have already exhausted all approved options to being used earlier, being used in combinations. We saw some exciting data for a combination of one of these T-cell engagers, teclistamab with daratumumab, which is one of the therapeutic antibodies that's really a mainstay of multiple myeloma therapy. And we're starting also to see some exciting data for newly diagnosed patients. And it really looks like even those patients that are very, very hard to treat, that have shown to relapse, have been shown to relapse for many, many therapies, that have high-risk disease, that have what we call extramedullary disease outside of the bone marrow, plasmacytoma, we're starting to see responses. So this is really showing us we're starting to turn multiple myeloma into a chronic disease that we can manage very well. And again, we're starting to think about cures, which is always really, really exciting to us at Blood Cancer United. So that's one area of excitement that, as all of you know, we've really laid a lot of the groundwork with the development of CAR Ts and all the work in this area that we've supported there.
My name is Jeff Lancet. I'm the chair of the Malignant Hematology Department at Moffitt Cancer Center in Tampa, Florida. And I am here at the ASH 2025 annual meeting. My specialty and research interest is in acute myeloid leukemia. So every year I try to pay special attention to all the new developments in AML. And this year has been a very interesting year for AML here at ASH. I think there have been a few really important and interesting research developments that are worth talking about. I think one of the most exciting aspects of AML that we learned about this year was how do we begin to think about approaching patient care between lower intensity therapy or higher intensity, more conventional induction chemotherapy for patients with newly diagnosed acute myeloid leukemia. And traditionally we have used a lot of intensive induction chemotherapy, which causes patients to be in the hospital for several weeks and has associated with several side effects. But then over the more recent years, we've been utilizing a less intensive regimen called azacitidine plus venetoclax on the outpatient side, mainly for older and maybe less fit patients that are not candidates to go through the more intensive therapy. And those results have been quite promising in the lower intensity therapeutic regimens. We've seen high response rates and reasonably good survival. So that led to the question of whether maybe we should be using the lower intensity approach across the board for both older and younger patients. And a presentation this year at the meeting by Dr. Fati at Mass General Hospital conducted a study, a phase 2 randomized trial comparing patients who had received either induction chemotherapy with one of 2 different regimens or the low intensity therapy with AZA plus venetoclax. And what they found in this large randomized phase 2 study was that patients seemed to maybe do even a little bit better with the low intensity therapy than the high intensity therapy. And that raised a lot of interest in, well, maybe we can really apply lower intensity therapy to not just older, more frail patients, but also to younger and more fit patients. So we need to do more follow-up and more detailed analysis of this study, but certainly raised a lot of interest in the possibility of maybe shifting the paradigm to a lower intensity approach that is better tolerated for not just older, less fit patients, but for all patients. So that was one really interesting and intriguing concept that was presented at the meeting this year. A couple of other really interesting areas. There's a new class of drugs called menin inhibitors, and these inhibitors are quite active in patients that have certain mutations within their AML cells, known as NPM1 or rearrangement of something called KMT2A. So patients with these abnormalities in their leukemia cells benefit specifically from a class of drugs called menin inhibitors. And we've seen from previous meetings and publications that even as a single drug, these patients with AML that have these mutations can achieve fairly high rates of remission. So now the interest is combining it with other more traditional agents in AML to see if we can actually improve on the results of the single agent menin inhibitor by itself. So this year we saw a lot of presentations looking at combinations of chemotherapy, such as what I just described, low intensity chemotherapy with azacitidine and venetoclax with one of the menin inhibitors. And looks very exciting with high rates of remission and high rates of clearance of these mutations that often persist in AML and lead to the relapse. So it's quite exciting to see that these combinations might actually induce a deeper response that could lead to longer and better remissions for patients that get all three drugs instead of just two drugs or one drug. And then we also have, I think, over the years developed an interest in understanding immunotherapy in cancer. And most of the immunotherapy success in hematologic malignancies has been in lymphoma and multiple myeloma with many of the new agents, CAR T therapies, and what we call T-cell engaging antibodies. But this year, for the first time, we're seeing some really encouraging results in AML with a drug called CLN-049, which is actually a novel antibody that attaches to both a T cell in the immune system and the cancer cell and brings them together. And this trial that was presented earlier today demonstrated that patients who had relapsed or refractory AML were actually responding to this new antibody-based drug in higher numbers than what we've seen in the past, including patients who've had very, poor risk or adverse mutations, where the chances of success with chemotherapy are quite low. So the fact that in this early phase study we're seeing promising responses and good tolerance of the drug is really, really exciting. And I think we're going to be hearing a lot more about this class of drugs moving forward for AML, both with this compound and other compounds, and hopefully in combination with known traditionally active drugs in AML. So a really exciting time to be studying AML, and I think the future is certainly looking brighter after this meeting than maybe it had in the past with regard to such great research being done. And so I'm excited, and I think there's a lot of hope to offer our patients with AML based on these developments.
I'm Ben Derman. I'm from the University of Chicago. I specialize in plasma cell disorders, mainly myeloma. And what am I most excited about at ASH? You know, there's so much that we really saw around immunotherapies in myeloma, specifically combination of CAR T therapy, bispecific antibodies, and even antibody drug conjugates. You know, right now we have cilta-cel that's approved for second line and beyond in myeloma as a CAR T therapy. There's also ide-cel, which is approved even after that. But one of the things that was really that struck out to me is that in these early lines of therapy, cilta-cel has a 30-month PFS that's basically 80% in standard risk patients. So these are the patients that actually don't have high-risk features. And we're seeing that at 2.5 years, 80% of them are still alive, not progressing, and apparently doing very well. So I think that's super, super exciting and something I'm going to take back with me about how do I talk to my patients about CAR T in these early lines. Tomorrow, we're going to see the MajesTEC-3 study, which is looking at teclistamab, which is a bispecific antibody, also targeting BCMA, and in combination with daratumumab. And it's against the standard of care. And we know already that this regimen is blowing the competition out of the water in terms of the standard of care. What it really means for us, though, is when should we be reaching for a bispecific antibody versus a CAR T therapy? And I think that's going to be something that we're going to be discussing now for a long time. These studies, can't be really compared head to head in terms of CAR T versus bispecifics. But boy, oh boy, I think what it means for us is we have great options for our patients pretty much at every line of therapy at this point. And I think what we're seeing is these bispecifics and CAR T are just going to continue to move earlier and earlier. And we know now that they're being studied even in the frontline setting, meaning when people are newly diagnosed. So I think that's what we have to look forward to. And the rates of deep responses like MRD negativity are really, truly awesome. We also presented some work this weekend around what do you do after people relapse after CAR T. So we had a combination with belantamab mafodotin, also known as Blenrep, in combination with carfilzomib and pomalidomide and dexamethasone. And we found surprisingly that over 80% of patients responded to this regimen. And not just that, they responded very deeply. And we piloted a longer interval dosing for the belantamab to try to reduce the blurry vision that can occur with this drug. And we found it to be actually lower than what's been reported before.
Hello, my name is Abdulrahim Yaqub. I'm a professor of medicine at the University of Kansas, and I treat patients with MPNs. I'm joining you from the American Society of Hematology at the conclusion of the meeting, and this is our annual celebration of blood research and blood cancer research. So we're excited about all the new information that we had to discuss this meeting. So I would like to discuss some of the updates in myeloproliferative neoplasms. In regard to polycythemia vera, we heard updates on the long-term results of a new therapy that is not yet commercially available, but soon will likely be an option for patients with polycythemia vera. The therapy is called rusfertide. The clinical trial was positive, and we got to hear about the long-term data and the long-term safety and long-term efficacy that is very reassuring. We look forward to having this option available for our patients in the near future. In regard to myelofibrosis has been a disease with few options. All the approved agents are JAK2 inhibitors, single agent. And in this meeting, we got to hear about combinations and regarding long-term safety and efficacy of some of the clinical trials. Unfortunately, nothing ready to come to the market and nothing ready to come to the treatment for our patients, but a lot of progress and research is going on in that direction. Among the most exciting agents that we have, and we've heard about this meeting, are the growing evidence of data for the CALR-specific therapy. So these are specific antibodies that are directed to CALR-mutated MPNs, and this is a subset of patients with ET and myelofibrosis. The results continue to be impressively safe and very effective, showing results that we haven't previously seen with any other agent in these diseases. So we're excited about this growing evidence of safety and efficacy, and hopefully we're going to hear more about that in the future. So we're very excited about all of this and look forward for more and more progress. We've also heard a lot about new diagnostics and new models to predict the patient's outcomes and prognosis. We've heard about updates and progress in bone marrow transplantation for MPNs. So a lot of exciting data and a lot of progress for our patients.
My name is Lori Muffley. I'm from Stanford University, and I'm excited to tell you about what I enjoyed most about ASH regarding acute lymphoblastic leukemia this year. So I think there are really amazing things happening in the field of ALL, obviously. At ASH, we heard about frontline combinations that are chemo-free, both in pH-positive and pH-negative ALL, and I think we're really entering a time where this is becoming reality. We heard about blinatumomab and ponatinib. We heard about inotuzumab followed by blinatumomab. And then interestingly, and I think the next forefront is really frontline consolidation with CAR T cells. And so we heard a couple of different trials with really absolutely phenomenal early event-free survival outcomes with just giving a single cell infusion after like 1 month of induction. So I think that is the next frontier. I'm super excited. And then in the relapsed refractory space, we also heard about new combinations and new targets. So the incorporation of venetoclax with some of our novel immunotherapies, I think, is going to be something we see more and more of. And then new targets. So for T-cell ALL, CD7 targeting CARs and BiTEs, I think are really coming. We have a couple of pivotal trials in the US for that underserved population that we're super excited about. And then there's other targets for B-cell ALL too that were presented at ASH. So very early phase trials, but really exciting. And I'm so thankful that people are continuing to invest and care about this disease. And I think the future is very bright.
Hi, I'm Gwen Nichols. I'm the Chief Medical Officer at Blood Cancer United. And my take on ASH this year is a lot of confirmatory data, a lot of data looking at how best to use the agents we already have, and then finally, a real emphasis, which I think is so important, on access to these treatments. As we start talking about trying to cure multiple myeloma with quadruplet therapy or with CAR T-cell therapy, we need to be sure that everyone can have access to that, and that people who are in underrepresented groups or live long distances from cancer centers have the ability to access that therapy if it's the right therapy for them. And so I'm really happy to see that ASH is focusing on equity along with all the new therapeutic combinations and learnings about the right therapies to give patients with blood cancers. So there's a lot of interest in AI, and there's a lot of fear. People are concerned that AI is going to put them out of work, that there won't be any generalists anymore, that AI will make all the initial decisions for patients. I think that's, well, certainly premature. Right now, we need to be responsible. It's our job to figure out how best to use AI and under what circumstances. And many of us are already using it for data collection, for understanding data that's already out there, for compiling information. But it still requires a medical professional to look through the data and be sure, much like what's on the internet, that everything you read has some validity, that you look at the sources, that you validate what you're seeing. And so I'm thrilled with AI. I love the idea. Imagine coming in with a whole list of medicines and saying, can I take this supplement? Will it interact with my other drugs? Most oncologists just can't even possibly have that information at their fingertips, nor is it easy to access. But if you plugged everyone's blood cancer medicines into the database and allowed AI to search for potential interactions, it could be life-saving. So I'm really excited about the effective and careful use of AI.
Welcome back. Thank you for joining us as we share these exciting highlights from the 2025 ASH Annual Meeting. The advances in blood cancer research we've explored today show how far we've come and how much promise lies ahead. Blood Cancer United is helping turn breakthroughs into real hope, paving the way for a future where more patients not only survive, but thrive. If you would like to see even more on the research that came out of ASH, be sure to check out the Blood Cancer United blog at the link below. We also encourage you to contact our information specialists at 1-800-955-4572 for the most up-to-date information on your specific type of blood cancer. Thank you for joining us. We'll see you on the next episode of Hematology Horizons. Take care.